Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much for the introduction. Thank you very much for the Saudi Society of Rheumatology for inviting me. And it's a pleasure to be here with you. I've been invited to give a talk about non-atherosclerotic cardiovascular disease or rheumatological diseases. Actually, when I received the invitation, I sent Dr. Hanan a message. Are you sure you want me to discuss non-atherosclerotic cardiovascular disease? Because usually what concerns us as rheumatologists is the atherosclerotic cardiovascular disease, which is by far much more common. But she said, yeah, we never heard about non-atherosclerotic, so we want non-atherosclerotic this time. And here we are. I'll be presenting non-atherosclerotic cardiovascular disease. I have no disclosure related to this presentation. I decided to state the most common pathology in cardiovascular diseases and then to talk about most common rheumatological diseases that's affected by the presented cardiac dysfunction or disease. So we'll start with pericarditis. In rheumatoid arthritis, pericarditis is quite common. It's seen in about 40% of patients, yet usually it's asymptomatic, and patients might present even with silent pericardial effusion. Most of the time, the changes of pericarditis is detected by echocardiography and by autopsy-related research. Interestingly, pericarditis occur more commonly in patients who are rheumatoid factor positive and in those who have rheumatoid nodules. In SLE, again, pericarditis is a common manifestation, but again, it is not clinically manifested. Patients present with feature of pericarditis are 20 to 50%, but most of the time will be detected by echocardiography. By autopsy, pericarditis can be seen in more than 60% of patients. They might come with chest pain. You might detect some pericardial effusion, although it is mild pericardial effusion, but in SLE, it can progress to severe pericardial effusion. Cardiac tamponade is rare. In systemic sclerosis, pericardiac involvement again is common, but again, it's not clinically significant. Fibrinous pericarditis is what can be seen in systemic sclerosis, and it's detected in 70% of patients. Small pericardial effusion is much rarer than what we see in rheumatoid arthritis and SLE. It can be seen in up to 15% of patients. Large effusion rarely seen. If it happens, it will be a poor prognostic factors. If we see pericardial effusion in patients with systemic sclerosis, we should investigate the kidney. Most of the time, it is associated with uremia or with cardiac dysfunction or severe hypertension in patients with systemic sclerosis. Myocarditis is the inflammation of the myocardium or the muscles of the heart. It's rare in rheumatoid arthritis, and usually it's not associated with any clinical symptoms, but it might increase the risk of congestive heart failure among patients with rheumatoid arthritis. In SLE, again, it's not frequent, but subclinical involvement of myocardial dysfunction detected by echo is much more commonly than seeing a patient with clinical manifestations of myocarditis. Impaired systolic function and wall motion abnormalities associated with myocarditis might be reversible in SLE if we start the treatment or controlling the inflammatory activity of the SLE at proper time. In SLE as well, it's quite important to investigate for underlying hydroxychloroquine-induced cardiomyopathy if there is any suspicions for that. The hydroxychloroquine-induced cardiomyopathy is a cardiomyopathy of unknown mechanism, but if we find it at proper time, it can be reversible. Once it gets established, it is irreversible. Myocarditis in systemic sclerosis, the right wall motion abnormalities can be abnormal in patients with systemic sclerosis even if they don't have any pulmonary involvement. And the involvement of myocardium in patients with systemic sclerosis might occur because of underlying pulmonary disease or because of renal diseases or because of hypertension. The risk of getting congestive heart failure or sudden death in patients with systemic sclerosis increase if the patient have myositis or if they have a diffuse disease. Again, in autopsy, there is fibrinous necrosis and fibrosis in the area of myocardium. The severity of this lesion is not associated with presence of pulmonary dysfunction or with presence of hypertension. And the fibrosis that we see in myocardium and in pericardium, as I mentioned earlier, it doesn't occur because of increase in the activity of fibroblast. Rather, it happened because of vasospasm of intramyocardial arteries. And this might result in seeing pseudo-infarction in patients with systemic sclerosis. And when the patient presents with pseudo-infarction, they come with typical chest pain of ischemia. Troponin might be high. ECG changes might be there or might not be there. But once you obtain history, they don't have a history of ischemic heart disease, no other risk factors apart from having a rheumatological disease. If you do angiography, the angiography is normal. Endocarditis is something that's not that common, or rheumatoid arthritis as well. Interestingly, those who have high inflammatory markers or they have positive rheumatoid factor, they are more prone to develop endocarditis. As a terminology, one of the endocarditis that we see in rheumatoid arthritis is merantic endocarditis. It is non-bacterial thrombotic endocarditis that might be only aggregate of platelets to large vegetation in previously undamaged heart valve. And if it happens, it will involve usually aortic and mitral valve. In SLE, although endocarditis is reported as frequent clinical manifestations, but it is by far a manifestation that can be detected by autopsy than to be seen clinically. The Liebman-Sack is the endocarditis seen in 15 to 60% of patients. It is non-bacterial vegetation, and most of the time it's found by autopsy. In systemic sclerosis, endocarditis is really rare, and if it is there, there will be an associated underlying myocardial damage. Valvular abnormalities in rheumatoid arthritis, it occurs in up to 30% of patients. Usually it is of non-clinical significance and it is not associated with any hemodynamic disturbance. It's seen as a mitral regurgitation or aortic root abnormalities, and they might have aortitis, which is a rare involvement as well. In SLE, valvular abnormalities seen in more than 50% of patients, and the vegetation is more commonly seen in mitral valve, but any other valve can be affected in SLE. Aortitis is something that we can see as well in SLE, as well as in systemic sclerosis, but it is rare. Now, valvular abnormality is something that's really important in ankylosing spondylitis because aortic disease and aortic regurgitation is well recognized in ankylosing spondylitis. It might range from mild aortic wall thickening without clinical consequences to rapid heart function deterioration and severe aortic regurgitation. If the patients have aortic root abnormality, 100% they'll be having aortic regurgitation. And the severity of the aortic root disease increase in patients with ankylosing spondylitis if they are older in age or they have a longer duration of ankylosing spondylitis. In echo study, aortic valve thickening and mitral valve thickening is seen in 40 to 50% of patients. Arrhythmia in rheumatoid arthritis, a conduction block might be seen in patients with RA, either secondary to granulomatous nodules or very rarely secondary to amyloidosis, something that we don't see anymore in the clinics. Once the changes in the AV system happen, rheumatoid arthritis, it is irreversible. We cannot restore it even with proper treatment. In SLE, isolated conduction defects are very rarely seen in patients with SLE. If it happens, it's usually in terms of sinus tachycardia, and it might be associated with underlying myocarditis or pericarditis. Sinus tachycardia as well might happen in patients with active SLE, and if it happens, it might be reversible with treatment. So in SLE, many of cardiological manifestations are reversible with proper treatment. As a note, we know that infants born to mothers with positive anti-Ro and anti-La antibodies are more prone to develop a congenital heart block, regardless if the mothers are SLE or not. As long as they have anti-Ro, anti-La antibodies, there is a chance of having AV block. So there is a recommendation to regularly echocardiography the fetuses of women with positive antibodies. In ankylosing spondylitis, arrhythmia is really important. Valvular changes and arrhythmia is something that we should pay attention to in patients with ankylosing spondylitis. Conduction abnormality seen in about a third of patients. The AV conduction block might be at the beginning intermittent, but might progress with time. Complete heart block can be seen in up to 10% of patients. Interestingly, conduction abnormalities more commonly associated or seen in patients who are HLA-B27 positive, and more as well seen in male patients than in female patients. Generally, those who have permanent pacemakers, 20% of them will have positive HLA-B27 regardless if they have ankylosing spondylitis or they don't. Electrophysiological studies show that most common level of block in ankylosing spondylitis patients is at AV node itself and not below that. It's not in the bundle of His. Atrial fibrillation is something that can be seen as well in ankylosing spondylitis, and it's more common in patients who are HLA-B27 positive. In systemic sclerosis, conduction abnormalities are frequently seen in ECG, but most of the patients are asymptomatic. Usually it's in terms of premature ventricular contraction, or they might have ventricular ectopy. Patients with symptomatic conduction defect will be having worse prognosis, and they are more prone to have sudden death. Coronary arthritis is something that we might see in SLE, but it is less common than having atherosclerotic cardiovascular problem. Pulmonary arterial hypertension is something that we see in 22% of RA patients, and it can be attributed or related to underlying interstitial lung disease, vascular disease, or chronic thromboembolic disease. In SLE, it can be seen between less than 1% to up to 43% of patients. Usually it's mild. Manifestations are very similar to idiopathic pulmonary hypertension, and to have a clinically significant pulmonary arterial hypertension is less common. Most of the patients are asymptomatic, and they'll be detected by echocardiography. Pulmonary arterial hypertension in SLE, it might be associated with intimal hyperplasia and thickness of the media, or it might occur as a result of pulmonary arteritis. And if you remember in previous slides, I mentioned that the arteritis is common in SLE. So it is a manifestation that happens in SLE and not in other rheumatological diseases. Patient as well should be evaluated for secondary pulmonary hypertension as a result of recurrent thromboembolic disease if they are antiphospholipid antibody positive. In systemic sclerosis, we know that pulmonary arterial hypertension is something serious that we should investigate by echocardiography. And if we think that we need a further confirmation, then catheterization is important. It happens in up to 35% of patients, and it is a serious clinical manifestations in systemic sclerosis and in CREST syndrome. So I have like 7 minutes more. I'll present some of echocardiographic findings that we found in our own patients in our site. We conducted cross-sectional study for 39 rheumatoid arthritis patients and 37 participants who are matching our RA patients in age, sex, and cardiovascular risk factor. A standard transthoracic echocardiographic examination had been conducted by a sonographer who was blinded to the clinical status of patients. We looked at different parameters in echocardiography, and we found that patients with rheumatoid arthritis do have more left ventricular mass and less ventricular geometry. As well, rheumatoid arthritis patients versus age 6 cardiovascular risk factor matched controls, they have higher or more left ventricular end-diastolic diameter, left ventricular systolic diameter, and left ventricular mass index. As increase in left ventricular mass index and increase in left ventricular mass is a risk factor for sudden death, we recommended in that paper a regular echocardiography to be done for patients with rheumatoid arthritis. This just to demonstrate how the left ventricular end-diastolic diameter, systolic diameter, and ventricle mass index is higher or more rheumatoid arthritis patients. In another paper that's under review, we looked at echocardiography in 52 RA patients and 58 osteoarthritis patients and 15 control subjects without any evidence or any changes of osteoarthritis, and all of them being matched for age, sex, and traditional cardiovascular risk factor. Again, the sonographer who did the echocardiography was blinded to the clinical status of the patients. We conducted left parasternal short and long axis 4-chamber and 2-chamber apical views. And despite that, all the participants, whether they were rheumatoid arthritis patients, osteoarthritis, or they were free of rheumatoid and osteoarthritis, matched with, in terms of traditional cardiovascular risk factor, doing blood pressure examination, rheumatoid arthritis patient showed higher systolic and diastolic blood pressure. As well, the rheumatoid arthritis group showed more wider aortic root than the osteoarthritis patients and the control subjects. As well, patients with rheumatoid arthritis showed more aortic regurgitation. In another abstract that we submitted for the coming EULAR, in a cross-sectional study, we recruited 47 rheumatoid arthritis patients and 63 control participants. And this time, we did not match them in terms of age, sex, and cardiovascular risk factor, but we excluded patients with history of heart disease or heart dysfunction, ischemic heart disease, transient ischemic attack, renal and liver failure, and pregnant women. On the same day of doing echocardiography, we obtained vitamin D sample, and we classified the vitamin D status to deficiency, less than 50 nanomole per liter, insufficiency 50 to less than 75, and sufficiency 75 to 250, and this is the categorization of normal reference for our lab. And analyzing the two groups, comparing the two groups, we found that there was no differences between the two groups in terms of age, sex, or in terms of history of hypo and hyperthyroidism, diabetes, or dyslipidemia. But rheumatoid arthritis patient group had more vitamin D deficiency, and they have more history of hypertension. We looked at so many parameters by echocardiography, and there were no differences between the RA and the other group in all these parameters, but rheumatoid arthritis patient showed higher chance of having aortic regurgitation. We did linear regression to look at the correlation between vitamin D level and all the parameters of echocardiography, and we found a negative linear regression and correlation between the left ventricular systolic diameter and vitamin D level, and the declaration time and vitamin D level, with more valvular abnormalities among rheumatoid arthritis patients. Now the question, how vitamin D might contribute to abnormalities in echocardiography. Vitamin D have been reported as an antihypertensive agent. It downregulates renin-angiotensin-aldosterone system. As well, vitamin D do have paracrine and autocrine hormone function in regulating insulin. Rodent with vitamin D deficiency do have abnormality in insulin secretion. As well, vitamin D regulate the level of metalloproteinases. So if there is low vitamin D level, there will be increase in metalloproteinases.
Dr. Saad, 1 minute.
I have a stopwatch in front of me. Okay, there will be an increase in metalloproteinases with more risk of having myocardial dysfunction and atherosclerotic disease. I have 1 more minute. So I don't think we'll be having a time to discuss atherosclerotic cardiovascular disease, but we know that patients with rheumatoid arthritis, and that's apply as well to all other rheumatological diseases with high inflammation, like especially in those with psoriatic arthritis, the 60% of them who have high CRP, they are at risk of more atherosclerotic cardiovascular disease, secondary to increase in the traditional cardiovascular risk factor as well as non-traditional cardiovascular risk factor, and CRP by itself have been reported as independent cardiovascular risk factor. Thank you very much. 20 دقيقة بالضبط.
Thank you.